Welcome everyone. Good morning on this warm. Well, you guys are in Rhode Island, and ladies, and everyone is in Rhode Island. I'm checking in from Massachusetts. Today we'll be covering outreach and engagement with individuals with co-occurring disorder, and I find it increasingly valuable for us to really dive into basics on co-occurring disorders, understanding the background, the connection, the basics, and the connection to trauma. Right, will help us better understand and be in a posture of offering the people that we serve grace. Right, that can enhance our ability to connect and have this, what we call in the clinical world, even though not everyone's a clinician on the call, a therapeutic alliance, right? A relationship to help support engagement. So again, I'm Daisy Hernandez, and I'll be the one working through the information I compiled here, but I'm a true believer that we all have our own lived experience, right? And in through a professional lens, right? And so I encourage you all to use the chat. If someone on the team can review the chat for me, because I can't see it because I'm sharing, that'd be very helpful. So we can learn together, right? Because we all come with lived or living experience, or we come with professional experience that could be valuable to the discussion. And I've accepted long ago I'm not the smartest tool in the shed, and I identify as a lifelong learner. So I'm open to receive anything that you may share just to add and enhance some of the information I've put together. Shout out to Rhode Island Housing, right, for partnering up with us and at C4 to put these workshops together. I'm sure you've probably heard of C4, but I'm super, and in this current time that we're living in America, I often say I'm really proud to be a team member at C4. But we are committed to advancing recovery, wellness, and housing stability for people who are marginalized. We are committed to reducing disparities and achieving equitable outcomes for everyone, not just for the partners that we collaborate with, right, but the people they serve as well. We engage, support, and partner with service organizations as well as communities and systems to develop and implement research-based and evidence-based solutions that are person-centered, recovery-oriented, and trauma-informed. And you can learn more about us through any of our social media handles or even our website at c4innovates.com. So what we're hoping that when you walk away this afternoon from this workshop, you've increased your understanding of the basics of co-occurring disorders through the review that we'll have. We'll touch on trauma and trauma informed or trauma and trauma from experiencing homelessness, increased understanding of the challenges impacting outreach and engagement of the individuals that we serve that do identify or are coping with symptoms of a co-occurring disorder, and recognize the balance between safety and self-care. And I feel like the relationship too, right? Because I think they work simultaneously to support us as providers in doing the work that we do, because the human work requires that human connection, and it's really emotionally and heavy on our hearts, right? Sometimes we get frustrated with the not being able to, or feel like we're not causing a positive effect of making the changes that the people that we serve are doing. And so we have to find that balance between safety and self-care. And if you're like me, I remember in the beginning working direct care, I would have like this emotional reaction to the term itself, self-care, and I like roll my eyes because I felt like I never got the opportunity by my leadership in when I was working in direct care to self-care. But we'll look at it differently in this workshop. Analyze the value of trauma-informed care and person-centered care, as well as the relationship and how it relates to shared decision-making, and recognize the art of engagement. Discover engagement in action with a scenario that I've put together. So first we'll look at basics of co-occurring disorders, which refers to having a coexisting mental illness or mental health disorder and substance use disorder, while commonly used to refer to the combination of both these, mental health and behavioral health disorders. The term can also refer to other combinations of disorders, such as mental health disorders and intellectual disabilities, which in my experience, and this is just a little sliver of a slice of pie, um, many of the participants that I work with in providing services or resources for individuals experiencing homelessness, intellectual disorders, or disabilities, were also part of that gambit of co-occurring disorders. All right, so the results from a 2021 national survey on drug use health, in which 69,850 69,850 respondents aged 12 or older completed a survey in person or via web data that said it highlighted 9.2 million adults in the United States as well living with co-occurring disorder. The survey also identified that 46.3 million people aged 12 or older had a substance use disorder in the past year. This includes a substance, alcohol, right? Not just like illicit substances. Of the participants of the survey who identified with having a substance use disorder, it was higher among American, Indian, or Alaskan natives. That was 27.6%. Multiracial individuals were 25.9%. Among individuals who identified as Black was 17.2%, and white non-Hispanics was 17%. I had Asians also were identified as 8.0%, and the percentages was lower among Asian people individuals who identified as Asian than among people in all other racial or ethnic groups. The same survey highlighted that 57.8 million Americans in the US were living with a mental health disorder. When substance use disorder and a psychiatric disorder co-occur, they may differ in severity, and the severity of each can change over time. Similarly, treatments and or medication for have require regular adjustments, right, based on having to treat both of them at the same time. You can't back in the days, right? When I was just a spring chicken, they would treat substance use separately to mental health. And some providers will say, oh, you have to treat the mental health first. Other providers will say you have to treat the substance use first. And it, through evidence-based and this kind of research, it was found that they should be treated at the same time, right? That dual treatment. Roughly half of individuals who have either mental illness or mental health disorder or a substance use disorder will have the other at some point in their lives, right? And at the same time, we can be, right, we think about the stages of recovery or the stages of change, we can be in action for a mental health disorder or in coping with symptoms of a mental health disorders, but still be in like contemplation with, I don't know, something like a cannabis use disorder. So, if you can share on chat, do you think that most common risk factors for co-occurring disorder is nature or nurture, right? Nature in terms of where the environments that we grow up in, situations, and nurture versus, how we are cared for and supported by, that those emotional and intellectual or emotional needs by our parents or our caretakers.
We've got someone in the chat that just said both. Someone else said that their guess would be nurture. Another says both. A mix of both.
That. Definitely both. Most definitely. And I think that unresolved trauma, as we'll get into it, the National Institute of Health asserts that drug and drug use and alcohol addiction can at any time during a person's life, and it may start at adolescence, but it's a period when the first signs of mental illness commonly appears. Right now, unfortunately, in this generation, right? Because when I was a spring chicken, some of the party drugs in my generation were things like ecstasy and benzos, whereas a lot of the stuff with our current youth are things like prescription opioids, right? Molly and those kind of drugs that do, really impact not just child development, but an adolescent's ability to, really cope with whatever reason got them to use the substance. And of course, any symptoms of withdrawal, not understanding those, right? If an individual does not have a mental health disorder and do use substances, they can develop a mental health disorder because substance use changes the brain and its chemistry. And this, real ripe and difficult stage of adolescent development, right? It really interrupts that process. And I try to describe it to the youth that I work with that something as simple as vaping, right, can really alter the chemistry of their brain. And I use a analogy or example of a computer. When a programmer is developing a computer and they're coding, let's say the keyboard, it codes it for the letters to fall a certain place. But when we introduce these substances as adolescent, when this process is happening, it really alters where the direction of the developer is instructing the computer and the computer doing what it wants and just falling wherever it wants. So then the keys are all messed up and you can hit a K but get a D. And I try to use it as something as simple as that. Majority of the time, the adolescents that I work with think of adolescent development just as the purity aspect of adolescent development, and they don't really understand the psychosocial aspect of um, adolescent development that does carry into adulthood, right? Just like, trauma and ACE scores, for example, have shown the linkage between childhood trauma and adulthood medical and behavior needs. If at any point you have any questions, feel free to ask. Like I mentioned in previous slides, mental health and substance use disorder have similarities to other conditions. Genetics is one of them that contributes to a disorder in the case of developing a mental or substance use disorder. Genes may impact, let me bring it all down. Oh, I went to tap happy. Genes may impact our risk when a protein influences how a person responds to a drug. Neurobiology determines the level of neurotransmitters produced. Determining how an individual responds to stress is another one. And this information was captured by Anita, and in a research project they had, they estimated that 60% of individuals' addiction is attributed to genetics, and most definitely can impact a mental health diagnoses or symptoms of a mental health. And then in terms of environment, right, or nature, environmental factors for substance use disorder and um, the increased risk of developing a current disorder. Environmental factors such as poverty, trauma, and peer pressure can lead to addiction, as do exposure to abuse, trauma, or neglect. These factors increase the risk of exposure to drugs and alcohol. They also make it more likely that someone will start using drugs or alcohol at an earlier age, right? And this is mainly around the population that self-medicates, right? Because individuals have many reasons why they use substances, and not all of them are for self-medication. So we look at mental health first, and I real quickly like an overview of those mental health that correlate or are more often connected to a co-occurring disorder. Mental health disorders involve changes in thinking, mood, and or behaviors. The disorders can affect how we relate to others and make choices. Reaching a level that can be formally diagnosed often depends on a reduction in person's ability. This is where a lot of individuals with intellectual or developmental needs. Serious mental illness is defined by someone over 18 having within the past year a diagnosable mental, behavior, or emotional disorder that causes serious functional impairment that substantially interferes with their limits, interferes with and or limits some of their major life activities. Sadly, too, right, there's this concept that a lot of individuals be it culturally, because of gender, because of their likes experiences, they don't really identify, like they can be having anxiety symptoms. And they're like, oh, I'm just tired. That's why I'm irritable. Or, they'll be shaking a lot in their legs and they're like, that just helps me calm down. But they won't identify having a mental health disorder. And if you recommend it, some people might even get offended, right? Like, oh, what are you saying? I'm crazy. And I'm telling you this from my own experience in my little nuclear family where my grandma would recommend to my mom to get some professional help for her mental health. And she always felt offended, like, oh, are you calling me crazy? And those kind of things. Now, for people under the age of 18, the term serious emotional disturbance is how they categorize. Trying to speak to the youth in terms that they would understand is how they categorize the mental health disorder, and how we educate on it as well. Now, the CDC back in 2021 did share that 50% of Americans are estimated to be diagnosed with a mental health disorder at some point in their life, and 20% can experience symptoms of a mental health disorder in a given year, right? And just like we're all so different, and medication works for some, medication doesn't work for another. We can present with symptoms, severe symptoms too, and be able to find a way to cope and just continue, meeting these milestones and living life. And other folks, it really interrupts their daily living and the quality of life. And there's really no exact way to determine, who will be able to manage it and who won't. And so we have to really be mindful and aware, right? Not to kind of create this cookie cutter format of what symptoms look like for a certain mental health disorder, because men present different symptoms than women. I mean, even with adolescents in a school, if a child is acting up, and she's a young female of color, they would, deem her as disruptive and not following, instructions. And if a boy does it, then it's like, oh, boys will be boys, right? And so we really have to be mindful to engage with this awareness, right? And humility to lean in that everyone is individual, because we really can't say that they're gonna cope with things the way we have coped with things if we've gone through similar situations. Now, the major types are of mental health disorders associated with co-occurring disorders are mood disorders that represent a category of mental illness in which the underlying problem primarily affects a person's persistent emotional state or their mood. Having a mental illness can make it challenging to live everyday life and maintain recovery for whatever substance it's making the co-occurring disorder diagnoses. The National Institute on the Mental Health Illness report on their fact sheet that 21 million people are diagnosed with a major depressive disorder, and 9 million postpartum individuals are diagnosed with postpartum depression disorder. And then the NAMI Fast Facts reported that 10 million people live with a seasonal affective disorder, and 7 million individuals live with a bipolar disorder. Anxiety disorder is another one of those common co-occurring disorders with substances. And those are characterized by persistent and extreme fear or worry, even when a threat isn't present. And anxiety disorder is also a symptom, or anxiety is also a symptom of trauma, right? And oftentimes there's a real clear connection between trauma and a mental health illness or disorder, and a substance use disorder. The other most common is personality disorders, and these are conditions in which an individual differs significantly from an average person in terms of how they think, perceive, feel, or relate to other individuals in the world. Said behavior deviates from cultural norms because it impacts how a person feels and distorts their beliefs about the person, or the people can lead to other behaviors. And then lastly, psychotic disorder, where people with psychotic disorder lose contact with reality and experience or have a range of extreme Symptoms characterized by abnormal thinking and perceptions, and usually includes hallucinations or hearing, seeing things that are not real, such as voices, as well as delusions, believing things that are not true. However, these symptoms, it can occur in people with other health problems as well, including bipolar disorder, dementia, substance use disorder. And when we talk about it in terms of, substance-induced psychosis, that also impacts some physical, behavior reactions as well. So it's important, invest in ourselves too and continue to develop those understandings of these different disorders that commonly occur with substances, so that when we're engaged with folks, right, one thing that is an ick for me is a lot of, and I'm in Massachusetts, not calling nobody out. I'm just stating where I'm checking in from. There's nonprofits I've worked in personally that really have this ethical alignment with the insurance company requirements, where if they're not connected for a certain period of time, they're non-compliant and have to discharge them, right? But people with co-occurring disorder, it should be best practices, right? For us to really dive into and understand why the participant is not connecting and how we can eliminate any barriers, because maybe they're not connecting as a result of one of their mental health disorders, right? Or a symptom of one of their mental health disorders. Now we'll quickly review substance use. So when we think about the 4 categories of substances and substance use, we got the opioids, right? The painkillers, and some of the examples are fentanyl, heroin, morphine, Percocet, and Vicodin. I did share some street names. I remember covering our recovery coach training and getting some of these street names from the participants that were there. Stimulants, they impact the nervous system and increase mood, attention, as well as energy. After And some of those examples are Adderall, methamphetamine, as well as cocaine. And Adderall, in at least the colleges that I went to, that were also party colleges actually, was really common for, students to be at the library in the middle of the night. And then me learning that some of them were on Adderall, and that's how they crammed their work. But it can develop an addiction as well. Hallucinogens, after a person's perception, it alters the person's perception. It may result in illusions or sensory distortions. I like to inform some of the youth that I work with in the clinical space. Cannabis, right? Now they're thinking, oh, cannabis is legal and I can use cannabis, and I don't have to go to the hospital like people who use heroin have to go to the hospital. And I kind of bust their bubble, right? Because cannabis has a lot of medicinal purposes, but not for young people, right? And again, it impacts that development process. And I help them understand that it's a hallucinogen. Yes, it has a lot of benefits for certain illnesses in adults, but there's not much research for youth. And I know for a fact that because of research, that it impacts their development. I haven't done follow-ups to see if this information has helped them reduce, right? But the kids that I'm working with end up in, are also connected to like supervision from DCYF. Depresses the nervous system, commonly prescribed for anxiety. And these are things like alcohol, Xanax, Klonopin, Valium, Ativan, and Neurontin, which are also a lot of severe anxiety medications that Klonopin, for example, I know there's recent research in the last, I want to say 2 to 3 years, where there long-term use of it can really affect our cognitive and intellectual abilities. And so, being able to inform the adult clients that I work with that have been on this for a long time, and or the combination of using some of these depressants with, I don't know, some prescribed opiates, right, for medication-supported recovery for opiate use, and the risk, it's important to really be informed so we can inform the participant that we work with. Now, I have another question. When does use go from recreational to disordered?
Someone in the chat says when individuals are unable to function without the usage, when your relationship with it changes, when it affects day-to-day function or safety, negative consequences. There's no clear line, but a disorder implies that it's disruptive to one's life and everyday activities.
I love that. Disruptive to everyday life. Exactly, right? And I think it's important for us and the work that we do to, really lean into the folks that we are working with that are practice a harm reduction or moderated use pathway of recovery and really ask those good open-ended questions to get them to self-reflect. Where am I in that spectrum, right? Am I, using recreationally, but still able to get up for work, and I still have healthy relationships in my life, and I'm still paying my bills, and I'm not homeless, and I'm not experiencing homelessness. I'm sorry. I didn't get in, and I'm not engaging with the police and so, right? So they can self-reflect on their own and make those decisions accordingly, right? On what pathway they use or what pathway they, want to transition into if they are in a moderated use or in a harm reduction pathway. So now we'll look at the role of trauma in co-occurring disorder. And for the most part, unresolved trauma is a significant contributing factor in the development of co-occurring disorders. Traumatic experience such as childhood abuse, combat exposure, or significant loss can lead to post-traumatic stress disorder, depression, and anxiety. So I remember a quick reflection of my education. I was my intentions were working human service, right? Human resource, right? I wanted to be a human resource specialist. And during my classes where I had to do a practicum, it was a practicum on equity and inclusion. And they wanted to have us do practicums in areas where service areas, right? And so I because of my experience, although I identify with a woman lived experience and lived and living, right? Because some days I have to work harder on coping with my mental health, depending on the season of my life, right? And so I share that, I grew up with men being the head of household and, keeping everything together while my mom was struggling with her own demons, right? And wasn't, taking care of what she had to take care of. So I couldn't understand why men were homeless. And so me opening my big old mouth, I was introduced or I was assigned, I didn't have a choice now, I was assigned to a male homeless shelter. And I learned so much, right, of veterans, which is blows my mind that veterans will sacrifice their life and then, not have the resources they need when they come back home to be in a safe environment. That severe mental illnesses, a lot of PTSD, and a lot of trauma. And it was probably one of the best internships or practicums that I experienced because it really broke down that stigma that I had because the danger of a single story where my single story was my stepfather was the head of household and he kept everything together while my mom struggled with her demons, right? But that wasn't the story for every male that was experiencing homelessness. So it was really important to engage and get to learn it in those type of environments that I wasn't familiar with, right? That I was ignorant to. Now, in an attempt to cope with some of these overwhelming emotions, individuals may turn to substances for temporary relief. Unfortunately, this can lead to addiction, further compounding the emotional and physical toll of trauma. Because once the effects of the use of the substance use is over, that those demons, right, are still there, impacting the individual's emotions and memories. Um, Now, some forms of trauma, I did mention some in the previous slide. Traumatic experiences such as childhood, combat exposure that I shared previously, and post-traumatic stress I shared it previously, and the depression, anxiety. In an attempt to cope with those, people may, seek temporary relief from anything, substances, risky behaviors. Unfortunately, this can lead again to, more secondary symptoms of a mental health and can really impact long-term um, presentation of these mental health disorders or symptoms of these mental health disorder can really impact, not untreated, can really impact an individual's recovery journey, right? I mean, it can impact physical health too as well. I mean, I don't want to leave that out. Um, Now, recognizing unresolved, right, trauma and the signs of unresolved trauma in individuals with co-occurring disorder is crucial for the effective treatment. Flashbacks is one of them, which are recurrent and distressing relocations of traumatic events, often accompanied by physical and emotional reactions. Even voice, hearing the voice of someone can really impact some of those flashbacks. Hyperarousal, persistent feelings of heightened anxiety, hypervigilance, and an exaggerated startle response. I was working with a colleague who has shared, she was working in another setting, and there was a delivery and someone dropped a box. And one of her colleagues that was a veteran crouched under a desk and was looking for her, like if she had the holster to her gun with her. And she said that she automatically, connected the fact that she's a veteran with she might have had like been hyper aroused by the drop of the box. And she said she felt so much sadness in her heart because she seen her colleague's face and it was just pure terror. But it was just a box that dropped, right? And a lot of the folks that we'll work with would experience this hyperarousal, especially individuals who are experiencing homelessness where, they're never safe, right? Have these experiences of hyperarousal because they're never safe, and so they always have to be in this like fight or flight mode. Uh, Avoidant behavior, deliberate efforts to avoid thoughts, feelings, or reminders associated with the traumatic event. There's these nightmares, right? Frequent and distressed dreams that reenact the traumatic event. And this could also be, from substance use as well as mental health. Substance use is the strong desire to use these substances. But in this case, with individuals who have unresolved trauma, it meets a need, right? It becomes kind of like a coping, and again, self-medication. Trauma is not always a singular event, but can be a series of experiences that compound over time. This co-occurring trauma often leads to chronic stress and emotional dysregulation, increasing the likelihood of developing a mental health and a substance use disorder or co-occurring disorder. Addressing these layers of trauma is essential for comprehensive healing, right? And this is going to really bring down that hyperarousal or avoidance of engaging with someone like a provider, um, because they're still, their trauma is untreated and they're still in this hyper or fight or flight stage where technically our fight or flight instinct was not developed or created for it to be activated 24/7, right? It should be only during moments. And then we think of the complexity of complex trauma, which although it's not recognized in the DSM-5, it's only associated with you can only diagnose someone, and I don't know how many clinicians are online with PTSD through the DSM-5, but internationally, complex trauma for this sustained long-term periods of trauma exposure is recognized internationally. Just a little fun fact there, Sarah, so she can get it to you all in some way. So when we talk about the challenges of outreach and engagement and the individuals with co-occurring disorder, the video would have really set it up for us. But tech is, trying to spar with me this morning. Challenges with engaging with individuals with co-occurring disorders include stigma, mistrust, and low treatment engagement, as well as where the provider is in this. If we think of, secondary trauma and um, the long-term effects that we experience from, working with complex cases, it can also impact their ability to engage in a healthy way. Co-occurring disorders are complex and associated with certain clinical challenges that can comprise the counselor or the provider uh, and the client's relationship and impinge on quality of care, potentially leading to suboptimal outcomes. Strategies for addressing these challenges include proper screening, assessment, diagnosis, and management. And working in teams, working in pairs is integral too. Practitioners are invited to engage in dialogue, right, with during group supervision with other providers that are working with individuals with co-occurring disorders to really understand how they're mitigating challenges, right? Because as colleagues, we learn not just from our trainings and our certifications, but we also learn from each other. Now, maintaining a recovery perspective involves continuous self-care of the provider, incorporating new experiences and avoiding isolation. Partnering up, I can't tell you how valuable it is. There's no words to being able to sit and have a coffee with my colleague or sit at a group supervision and say, hey, I'm working with this individual that is presenting like this and has these needs. Have y'all ever, as simple as that, have y'all ever, worked or supported an individual with similar situations? Right? And then we can really begin to increase our awareness around how we support individuals. And it becomes a collective support too. Some of the recommendations from tip 42 from SANSA is assess each client's stage of change, right? Thinking of providing an individual resources that is in action but the individual is in pre-contemplation, it's gonna create a barrier to or a challenge to engagement. Ensure that the treatment stage and expectation are consistent with each client's stage of change and that the individual has a say, right? And is uh, properly and fully informed of the options or resources that are out there so they can make the informed decision. Use client empowerment to motivate change. I cannot tell you how many times during peer work and clinical work, I have sat and asked an individual, oh, so what are your strengths? And they'll literally be looking like their eyes will be rolling around in their head, like they're looking for an answer in their head because they can't identify a strength, right? And so what I'll do is I will like go through the intake session, and then as they're telling me stories, and I'm like, I'll pull those strengths out. So and then they start really realizing like I am strong, like I do have some strengths, I am resilient, I've overcome a lot, right? Also foster continuous support. When I have folks that have been assigned to me from the courts, and I know as a clinician, and I've accepted long ago that therapy is a pathway, but not the pathway, right? There's individuals that, like I said earlier, can manage symptoms of a co-occurring disorder and live healthy, positive, productive, lives. And then there's folks that need more support. And for the folks that do need more support, but are being forced by, I don't know, the Department of Children and Families or probation parole, there is naturally gonna, because they're being forced, right? There's naturally gonna be this pushback and, trying to empower and motivate, inspire that intrinsic motivation of individuals to really look at what they see their needs are, can support engagement. Um, um, Maintaining a recovery perspective is also fostering continuous support. So for these individuals, when they discharge or meet their goals and they want to discharge, it doesn't like, I always give them my business card and I say, please always consider me a resource, right? Because they've met their goals today, but in the next season of their life, now they have some other things that are falling apart, right? And if I don't know, I connect them with a resource. And that, although our caseloads right nowadays are a little, we're a little expanded on the amount of caseloads that are assigned to us, right? It could feel like a big load or additional work that we're not being reimbursed for, right? But being able, how we treat people, right? And in terms of when we engage with them through a recovery perspective, is being able to continuously be a support for them so they know something's happening in my life. I know Miss Daisy can connect me with somebody or resource that will connect me and help me meet this need. And it it does also help engagement in the future to provide a continuity of treatment. So even if, let's say that one of my participants with co-occurring disorders has completed their goals or is not no longer in probation and doesn't want to continue with treatment, being able to connect them to a step down version, like a peer recovery center or a club or a cafe where when, they do have needs, they could connect there, or even some 12-step groups or something. And then we also have um, acknowledge that recovery is a long-term process, support and applaud even small gains by the client. Sometimes, oh, somebody has a question here, hands up, Caroline.
Hi, yes, we have a question in the chat. How do you help with individuals maintaining recovery perspective when there are limited availability for resources? Some things I struggle with are housing or shelters/housing availabilities not being openly available, which can often lead to individuals becoming discouraged.
And feeling hopeless, definitely. And I think that's a problem in Massachusetts. Well, I don't think so. I know that's a problem in Massachusetts, right? Where the resources are limited, and what is there is oftentimes full or in a waiting list. I often encourage, becoming part of recovery communities where I can't tell you how many times, and it hasn't been always successful, partnering, connecting individuals with peer recovery centers are gems in our recovery communities where if as a provider, I don't know, a private landlord, or I don't know a new program that's coming up. The peer recovery centers and the individuals, the peers in the peer recovery centers, they know everything and anything that is moving around the peer recovery supports, like spider web of resources. And connecting our individuals with those recovery communities can often lead to roommate situations, can often lead to, if the individual, engages with folks, can often lead to temporary situations. And we have to be the optimistic mind too, right? I've even been told that I annoy people with my optimistic mind, and I'm like, listen, hope is the last thing we lose, right? And so being able to like encourage for at least this moment today, how can I help you today, right? Sometimes I've even told, well, this is unethical, I believe. I've even told folks like, go sit in the ER if it's like 200, 20 degrees outside and it's freezing, right? Go sit in the ER as if you're going to see them, complain of a headache or something so you can have a warm space. I remember my grandma, even she would use her her bank card to let people sleep in, like, those ATMs that are in like closed little spaces, locked spaces, and she would let folks sleep there as if it was her. But being innovative and partnering up with organizations and peer centers to look for at least temporary solutions. Um, I know a peer too that made a good relationship with a shelter, and they always held 3 beds for them for like an hour after the deadline. And if they came from the center, they would let them get those beds, or they'll leave it open for other people if nobody ever came. So there's, it requires a lot of innovation, and that really impacts us, where we feel like we can't help, right? Like the people that we work with have these needs, and we can't help. And speaking to folks about harm reduction, right? Difficult times can be get us to that point where we're feeling hopeless, and being able to encourage folks. Okay, so if this is your last resort, please, have you heard of harm reduction and how to keep yourself safe if you do have a return to use, or if you feel like using. So giving them those tools as well. I hope that answered your question.
She said yes, thank you.
That was hard even for us, maintaining that positive recovery perspective when waiting lists are 20 years long or some preposterous thing like that. But now back to the providers that are the real heroes in the face of this work. Balancing safety and self-care in outreach and engagement of individuals that are dealing or managing symptoms of co-occurring disorders are also experiencing are also experiencing homeless, and involves proactive self-care approaches, overcoming barriers, and sharing self-care practices. And self-care practices is more than just getting your hair and nails done, ladies, and it's more than going to the gym, gentlemen. Um, it's more than that basic, right? And it should be on a regular basis. Like, I know that every 2 weeks, my son and I go on a date. Don't tell him I told you it's a date because he doesn't like me calling it that. But I have to plan it on my schedule just like it was a doctor's appointment, right? And to understand self-care, it is helpful to consider what it's not. Self-care is not an emergency response plan to be activated when stress becomes overwhelming. Self-care is not about acting selfishly. All about me, right? Mentality. Self-care is not about doing more or adding more tasks to an already overwhelming to-do list. Healthy self-care can renew our spirits and help us become more resilient. Self care is more effective when approached proactively, not reactively, right? So creating a pattern and a routine for you and switching up those activities that help you disconnect from the work that you do and really connect with self and the world around you, your network of support. And that's what I mean in terms of your world around you, right? Now, the value of trauma informed care and person centered care. Um, and tension exists often between feeling inspired by our work and feeling frustrated about the many things we cannot control. And I like to mention this with self-care, right? Oh, I feel like I'm in the wrong slide. Hold on. It does say ABCs of self-care, right?
Yes.
Okay. Tensions often exist between taking care of ourselves and feeling inspired by the work we do. And then this frustrating part of the work where we feel like we cannot control or have real positive impact in our individual's recovery journey. It is not usual to feel stressed and weighed down for working with individuals who are managing co-occurring disorders and experiencing homelessness. This is why, going back to the previous slide, it's so important to make it a regular thing and not or self-care a regular thing, not a reactive thing, right? And it requires awareness, right? What is my norm? When I am working at my best, what does that look like? How do I feel when I'm working at my best? And having balance, as much as I think balance and advocacy should go together in this one because, right, if we want to, I don't know about you all, but if I want to take a vacation, I really think about it, right? And what days I take on vacation because I don't want to go out and take a vacation to self-care and disconnect, but then come back to 1,000 emails, right? So strategizing a balance between, okay, I'm leaving for this amount of days. Can someone respond to some of my emails? Can someone work on some of my tasks, right? And partnering up with my colleagues and advocating to my supervisor for support in mitigating those worries or challenges that I foresee when I come back from vacation. And connection, right? Like I shared previously, connect with peers or your colleagues, connect with things in your community that, I don't know, it might be free in your local library or museum, have like a free, art show or something to help you really disconnect. Connect with your colleagues, right? During group supervision, what kind of self-care activities are y'all been into, right? And try to look at ways for you to, other ideas for you to use self-care time to really replenish yourself because that's what's most important. And again, self-care is not selfish, especially in the work that we do. It's probably as necessary as going to our doctor's appointments or what is it? I know I work in a part-time, I work in a clinical office. They require from us like the flu shot every year and some like the COVID shot every year or something. It's just as important as those things, right? And your health needs. So now, any questions, thoughts so far? So we'll review quickly values of trauma-informed care and person-centered care before jumping into shared decision-making that really lights the load for us in doing some of this hard work. So trauma-informed care is an approach that emphasizes the recognition of trauma's role in mental health and addiction. It focuses on creating a safe and supportive environment that acknowledges the potential for trauma in individuals seeking support or treatment. And we often carry that secondary part of it where, some of the experiences of the individuals we work with, we might um, think about at home or impact our mood and behaviors at home. So with safety here, it's creating a safe and welcoming environment where individuals feel comfortable sharing their experiences. Similarly, right, this in terms of work cultures, right? This idea of safety also relates to the work culture, right? And who is our supports when we are feeling impacted by some of those secondary effects from doing the work that we do. Then we have trustworthiness and transparency, which is building trust by providing clear and transparent communication. Similarly, in your work culture, right? Who is that person? What do you have? What if you have a supervisor that you and them don't really like you don't feel super trustworthy, or a culture where some things that you've shared might be shared around, right? We have to be intentional in advocating for safety and trustworthiness in our cultures too, so then that we're not deflecting that the side effects of those things with the people that we work with. Peer support, encouraging peer support among individuals who have experienced similar traumas, right? In this case, we're looking at this, right, for people working with co-occurring disorder, but I'm going to always find the connection of creating a trauma-informed work culture where individuals can feel supported by each other, feel safe, and feel trustworthiness and transparency. Collaboration, ensuring collaboration among professionals to address mental health disorders and substance use disorder. And this collaboration, just to use the example from the comment, can very easily be ensuring that at the local homeless shelters or shelters for the unhoused, that you always have a contact person there, right? So that what's new coming down the pipeline, or in your own city, or in the your hotlines, right? That of any new programming or any housing availability projects that are being developed, because housing, it's a national crisis. I feel I just seen somewhere that Amazon is selling like container houses or something. I'm like, this is genius. Like, why we can't find like some lot somewhere as a state, and I'm speaking from in Massachusetts as a state, and plop a whole bunch of them there and roommate folks, or do a program where they can end up owning it. I don't know. There's so many ways to do the work, but in terms of, I don't want to digress, in terms of collaboration, ensuring that in the right places, you have relationships and you can collaborate with folks in the places that are meeting the needs of the individuals that you are working with. Empowering individuals to make choices about their treatment and recovery. And this comes, we'll touch on it, with shared decision making, right? And ensuring that we are giving the proper information for individuals to make informed consent and make decisions for themselves. Cultural sensitivity, leaning in with that humility that you don't know, even if, and I always say that using myself as an example, as a Latina Puerto Rican that grew up in the north end of Springfield, Massachusetts, and was able to travel back and forth many years, every year since migrating over to the United States from the main from Puerto Rico, that we call it the mainland over here, but my experiences are not similar as a woman Latina that grew up, let's say, in New York, or grew up consistently all their lives in Puerto Rico. Even if we have the same cultural identity, even if we have the same trauma histories or the same substance use that we're recovering from, our experiences is not the same, and it requires us as providers to really lean in with this curiosity to fully understand how the role of culture um, and the beliefs of the individuals based on their culture around substance use, mental health, and these co-occurring disorders, as well as some of their trauma experiences. Incorporating trauma-informed care into treatment or community supports for co-occurring disorders allows for a more comprehensive and effective approach to healing, but it really empowers individuals and it gives them this comfortability to lean on or partner up with you around the needs that they have, right? Because you're validating all these aspects for them, right? And safety, trustworthiness, and transparency, peer support, collaboration, empowerment, and cultural sensitivity. Now, with person-centered care, here we're treating patients as individuals, as equal partners in the business of healing. And the recovery coach, I was a recovery coach before I was a clinical social worker, and we call this, the individual, the people that we're working with being the expert on their own life. Some people still frown their nose up or, around this. But the reality is we get to meet with individuals an hour, 45 minutes, a week, bi-weekly, maybe sometimes once a month. They live in their life and their full selves 24 hours a day for how many years they've been alive, right? And so who are we to come in and say, oh, this is what you should be doing, versus partnering up and saying, okay, so you're identifying this as a need, this as a need. What have you tried before? What has worked for you before, right? Have you ever heard of, I don't know, some other resource, right? It is shared decision making. It is personalized, coordinated, and enabling in a positive, enabling way. It is not a medical model and should be regarded as multidisciplinary, recognizing the person may need more than one professional to support them, right? Again, we can't be the is all end all for all the needs that our individuals have. And through that, engaging with the people that we work with through this you're the expert in your life approach, it lightens the load for you, right? And I don't know more resilient people than people in recovery from substance use and mental health, because they know what's out there and they communicated to each other resources, all right, they're their best resources. But how do we connect them through that bureaucracy and all those barriers around, oh, you need this insurance and you have to get a consent or consent from your doctor and you have to do this before you do that and you're going to be on the waiting list for 90 days before you can see a case manager. How do we help them navigate those things, right? That by eliminating those barriers, then we can increase their confidence and feeling like I'm getting things done. I'm resilient. I can figure this out. It's going to take me a little bit, but I can figure it out, right? Now, working in this way means recognizing people's capabilities, potential to manage and improve their own health, and meet some of the easier basic needs, not seeing them simply as victims of a disease or passive recipients of a care. Um, but most people want to help themselves. So being able to engage with them through a person-centered approach, long-term effects of their experiences through substance use and mental health really kind of like beat down their confidence around, oh, I can't do this, or this is too much, or some of the barriers mentioned in the sample of the question, right? That there's barriers to access or availability. It really, disencourages them to feel like they can make decisions for themselves. And through person-centered care, then we can ask these good questions to increase our awareness of where the participant is, what they have tried, and always, respecting the individual, treating them with dignity, understanding their experiences and goals are valuable, maintaining confidence, right? Again, that sense of safety, and trust and transparency, giving responsibilities. I always give homework, even if it's as simple as this just happened to me. An individual was working with a case manager, but he missed an appointment because he got memory issues. So they one of the organizations discharged him because he had missed 3 appointments in a row. And so I told him, okay, so this is what you can do, and this is what I can do. I said, if you can compile me a list of everywhere that you've applied, I can be looking at additional resources that you haven't applied to. And I asked him if he's ever, thought of renting a room from one of those like boarding houses or houses that individuals like sober homes. I'm sorry. And he wasn't aware of sober homes. So, I introduced him on that pathway. So it just requires us really giving in and leaning in with curiosity to really know what they know so then we can offer additional supports. And giving responsibilities also makes them feel right. Like even if it's a small accomplishment, when they do it and you celebrate it, they feel encouraged again, right? That they are making strides for as small as they are, in coordinating care, right? So it's not just, hey, I put a referral for this place, so wait for a call, right? I can call too, right? When I'm updating his file on a weekly basis or putting in his note, I can shoot an email over or send an email over to the contact from person in that organization to really just follow up in case the individual didn't follow up, right? And then working with individuals who experience homelessness, right? Their access to phones, their access to computers, and those kind of things, it's not readily available, right? But also looking at resources that can meet that need or that barrier for that need of having access to a phone, even if it's, engaging the peer center and they have a peer phone there, or engage with this organization. They hold mail for individuals who are experiencing homelessness, right? It's coordinating care for all those needs. Of course, prioritizing basic needs, but any additional needs the individual might have. So here we are with decision making. Shared decision making is an emerging best practice in behavioral and physical health that aims to help people in treatment and recovery have informed, meaningful, and collaborative decisions with providers about their health care services, and other social services. It can enhance recovery by helping people become more active in their mental health care and substance use care, as well as their personal recovery. Shared decision making is coherent with recovery oriented and mental health services and results in better informed patients and fewer conflicts regarding decisions. It can only help the engagement and even in the outreach stage of initially engaging individuals. Four basic elements of shared decision-making process. This shared decision-making can enhance recovery by helping people become more active in the mental health care and personal recovery decisions. It also engages practitioners by providing them with a way to communicate with people that recognize the value of the service client, the service user. There are four basic elements. These elements, the first one is establish a partnership. Individuals have the right to make choices about their treatment and services, but people make their best decisions when they have good information, consider the input of others, and take time to think through what is most important to them. Exchange information. People using services discuss their experience, history, preferences, values, cultural beliefs, and what has worked or not worked in the past. And similar with establishing partnerships, leverage some of the treatment groups to dedicate at least one day a week, one day bi-weekly, one day a month, where they are the resources, right? And they come in and share some of the resources they know with other members of the group. In terms of just continuing on engaging information, shared decision-making tools describe in more detail can also be helpful to identify the different needs and then help partner up with the participant to prioritize them, right? Which one is more important for them at the moment? Weigh in options together with the provider and the individual who's seeking the services. They can weigh in on pros and cons of each option in the context of the individual's preferences, values, and cultural beliefs. Watching waiting, that's often that's sometimes our role, not often, right? Because we have folks that could really be gun ho and a go-getter and get things done, and other folks who really struggle because of the severity of the symptoms to really prioritize and weigh those decisions. So having conversations on pros and cons to really identify how they prioritize their needs can help, kind of increase awareness for the individual that you're working with, and them feeling, like you are giving them that power back, really does support engagement as well. And making a decision. The process of decision making is shared, but the final decision rests with the person using services. And sometimes, or engage with the services. And sometimes we have to reiterate that, right? Because people with co-occurring disorder and people experiencing homelessness are often treated less than human, right? Even in, behavioral health and mental health, there is stigma and bias, and individuals, then they engage with us and we're engaging with them through this shared decision-making process, and they are feeling validated. They're feeling like they're having a choice, a decision, and they get to make their own choices, will boost engagement like better than like mandated treatment. But the key to all of it is really being informed, right? And knowing what the referral or resource referrals sources require, knowing what the participant will need once they come through the door, knowing as much information of the resource as possible so the individual themselves can make the informed decision. Now, the art of engagement and building positive alliance, research suggests that a therapeutic alliance is strong. And when we think about therapeutic alliance, it's not just through a clinical lens, right? It's also through a direct care lens, like that working relationship that you're building with the individual that you're serving. If not essential factor in supporting recovery from mental health disorders and substance use disorders. The therapeutic alliance can foster desirable outcomes by improving symptoms, functioning, treatment engagement, treatment satisfaction, and quality of life. To foster treatment engagement for individuals managing symptoms of co-occurring disorder, therapeutic relationships must build on clients' existing capacities, right? So someone with a having developmental needs or intellectual needs is not going to necessarily be offered the same resources as an individual that is fully aware of their needs and or has some ability to find resources for themselves, right? To foster treatment engagement for clients with co-occurring disorders, the relationship that we built, the working relationship that we built, is integral in supporting the individual with the cornerstones of co-occurring disorder recovery process. Right. And also, being able to find those resources that treat both. So guidelines for developing success, demonstrating understanding and acceptance of the individuals that we're working with, help clients clarify the nature of the difficulties that they're experiencing, and understanding how they perceive those first and foremost. Indicate that you will work together with the individual, communicate clients that you will help them help themselves, right? And always having that pros and cons conversations around these are the resources that are out there and these are some of the pros and cons. What do you think about the information, right? Express empathy and willingness to listen to individuals' understanding of their problems, and assist clients in solving external problems directly and immediately, right? Sometimes the least that we can do is see how we can support them at the moment, because like something for housing like that, we know that's a long-term process unless they just open a new sober home or open a new, boarding home or something in your neighborhood. Some of the guidelines are develop and use therapeutic alliance to engage clients in treatment, maintain a recovery perspective, ensure continuity of care, address common clinical challenges. We are not clinicians, right? We're working direct care, but if we partner up and collaborate with someone in our organization who is a clinician or some outpatient clinic in your area to help address those challenges would be helpful. Monitor psychiatric symptoms, right? Not that we're psychiatric specialists or, again, clinicians or mental health counselors or drug and alcohol counselors, but we get to know what the individuals that we're working, what their baselines are, right? And being able to say, hey, you haven't shaved in a while. Everything good, right? Maybe it's just simply I don't have a razor to just been unmotivated and I have an interest in doing anything that I used to do before or something like that, right? Use supportive and empathic engagement and adopt a multi-problem viewpoint and how, and gaining that understanding that these multi-problems that are impacting their quality of life can and most definitely will affect their emotional health, mental health, and behavior health. Use culturally responsive methods, and this is where we lean into the participant that we're working with so that we can better understand, those cultural sensitivities or cultural humility aspects to their care. Use motivational enhancement that's really supported by motivational interviewing and develop those skills. I don't feel like I'll ever be competent in motivational interviewing because it looks different for the individuals that I'm working with, also based on, through that lens of cultural responsiveness, teach relapse prevention and harm reduction techniques, right? We're not going to always be there by their side to support them, but they can most definitely do it for themselves and use repetition and skill building to address deficits and functioning. Engagement and action. So now we have this little case study I put together. And I'm going to read it unless somebody wants to volunteer and read it. But my goal is for us to identify nuggets around reflective trauma, identify nuggets reflecting on trauma-informed care, person-centered care, or shared decision-making. If no one would read it, I'll okay with reading it. All right, so I'll jump in here. And I made it kind of easy with Linda being assigned to find a sponsor. But Linda's a 24-year-old woman, had attended her mutual support group for about 3 months. Although she knew she should ask someone to sponsor her, she was shy and afraid of rejection, right? Some complex trauma responses there, right? Ashamed, afraid of rejection. She had identified a few women who might be good sponsors, but each week in counseling, she stated that she was afraid to reach out. I don't know if anyone's had a client or worked with someone that way, with that fear that hinders them from making choices in their recovery journey. No one had approached her about sponsorship either, although the group members seemed friendly enough. The counselor suggested that Linda share, and the counselor could be, a case manager in this for this purpose, a case manager, a peer supporter, a clinician, right? Or a housing specialist. So the counselor suggested that Linda share in the next group meeting that she'd like a sponsor, but has been feeling shy and hadn't wanted to be rejected. The counselor and Linda role played this act of sharing during a counseling session. The counselor reminded Linda that it was okay to feel afraid and reassured her that if she couldn't share at the next meeting, they would talk about what had stopped her after the next meeting. Linda related that she also shared but got scared at the last minute. She felt bad that she had missed an opportunity, right? Those feelings of shame and guilt. She and the counselor talked about getting it over with, and Linda resolved to reach out, starting her sharing statement with, "It's hard for me to talk in public, but I want to work this program, so I'm telling you all that I know it's time to get a sponsor." Can anyone identify some nuggets reflecting trauma-informed care, person-centered care, or shared decision-making?
We have someone in the chat saying it's more helpful to explore with Linda what was getting in the way of asking for a sponsor rather than directing her to get a sponsor.
Mm. So it didn't feel much that there was much shared decision making there, right? And again, it probably it sounds with the comment like the counselor was lacking strength in the area of motivational interview and asking those questions, those good questions that can get her to self-reflect on that. So in this example, it was Linda had developed a rapport with her counselor in talking about her needs, but that comfortability that she had with her counselor wasn't translating in her group, because she wasn't really engaging with folks from that fear, right? Validating, the counselor did validate the fear, but it wasn't person-centered in a way where she dug deeper in what was hindering her from asking these questions, and or even, validating or making the connections between some of the feelings of fear, rejection, feeling shy. And fear can be debilitating, right? It can really freeze us. And giving Linda that information, so that she understands why she's having some of these, or see the connection between some of the experiences that she's had with some of that fear of rejection that she has now, so that she can feel a little more confident on sharing, or even, asking her what other, people in the place herself in the group space, she relies on, or she's close to help her, build that confidence or feel supported at that moment when asking somebody, and asking these good questions around, would it be better to ask an individual by themselves or out in a group, in an open group. So exploring is so important to really help the individual self-reflect on those things that are hindering them from achieving some of their health and wellness goals. All right, well, we're coming up on time. I always like to share a little quote, that if I can turn my computer around, I often change my little quotes on my whiteboard and my wall. But the one I had this week was, "The gem cannot be polished without friction, nor man perfected without trials." And it's a Chinese proverb, but I found it appropriate for, working within human service. I think that it's we have a lot of needs, individuals with needs, and not lining up with the resources that are available. And sometimes we can feel discouraged, like no progress is happening and we don't have control to support the people that we're working with the needs that they have. But through trials and tribulation, collaboration with other providers, collaborations with our colleagues and our leadership, then we, can be perfected in the work that we do. But we also got to take care of ourselves. Don't forget that part. If anyone has any questions, comments, concerns, we still have about oh, we're at time actually, but I'll be happy to, to stay a couple minutes if anybody has any questions, thoughts, or concerns.
Thank you everyone for joining. We'll be sending out the recording and the slides. I believe that either Sarah or Rosa from Rhode Island will be sending them to you, as well as some surveys and evaluations. Have a great weekend.